And a very warm welcome, and it is warm, to the sixth session for the Pensioner Poverty Inquiry. And it's a pleasure to welcome Professor Sir Michael Marmot to the committee. Michael, would you like to introduce yourself? We've got a few minutes just to go through the list of things that you have been involved in.
I'm Michael Marmot. I'm Director of the Institute of Health Equity at UCL, University College London. I chaired the World Health Organization Commission on Social Determinants of Health, which we published in 2008. And Gordon Brown was Prime Minister then, you remember him? And he invited me to conduct a strategic review of health inequalities, asking the question, how could we apply the findings and recommendations of your global commission to one country, England? It became known as the Marmot Review, as these things do, Fair Society, Healthy Lives, which we published in February 2010. I don't think there was a causal connection with Labour losing the next election. At least I hope not. But the Conservative-led coalition government issued a public health white paper and said it was the government's response to my review. I thought, this cross-party thing is a doddle. It was commissioned by a Labour government. A Conservative-led coalition government has adopted it. I was really pleased. In the event, the policies of austerity were not conducive to improving health and reducing health inequalities. And so my 2020 report, the Marmot Review 10 Years On, documented the fact that health had stopped improving pretty much. Health inequalities had got bigger, and health for the poorest people had got worse. Life expectancy had gone down. And then 3 years of the pandemic, life expectancy fell. So we went through a 14-year period from 2009 to 2023 where life expectancy did not improve at all. And health inequalities got bigger, and life expectancy for the poorest people declined, and self-reported health got worse.
Thank you, Michael.
That's
wonderful. We've all got questions for you, and obviously this is around the Pensioner Poverty Inquiry in particular. So I'm going to kick off. So I wondered, in terms of from your huge knowledge, how does poverty in earlier life affect pensioner poverty and being poor in retirement? And how does it also affect health over the life course?
Well, what we know, in general, that rich parents have rich children when they grow up, poor parents have poor children when they grow up, middle-income parents have middle income, and that's true in every country in general. But the magnitude of that effect varies. And one way of looking at it, forgive my citing some technical numbers, but one way of looking at that mobility is to ask, at the current rate of social mobility, how many generations would it take for someone in the 10th centile of income to get to the median? In Denmark, it would take 2 generations. In Finland, Norway, or Sweden, it would take 3 generations. The average for OECD countries, the Rich Country Club, is 4.5 generations. In the UK and the United States, 5 generations. In Brazil, 9. We are heading to Brazil, not to Denmark. Why these big differences? 2 kinds of explanations. The first is the magnitude of income inequality. What the data show is the bigger the income inequality, the more the income of adult children resembles that of their parents, the less social mobility. And the second is investment in early childhood. And again, citing OECD figures, the average investment in early childhood is about $6,000 per child aged 0 to 5 per year. Norway spends 12,000. The other Nordic countries, 9, 10, France, 9,000. We're about average. We were below average, but the latest figures suggest it's about 6. The US, 3,000. Brazil, lower than that. So what we're doing by having less social mobility, we're guaranteeing a lifetime of low income.
Including pensioners.
And that will feed right through the life course. And we know, given that, we know that socioeconomic circumstances predict ill health right up through the oldest age. So it's not, for example, in the US, there were data suggesting the black-white differences reversed at older age. So blacks have higher mortality than whites, but that reversed at older age, and that led to people speculate on some kind of survivor effect. You know, if you can get to older age as a black man or woman, then you must be really hardy to survive all that. But we don't see that in Britain when we look at socioeconomic differences. We see that the poorer you are, the worse your survival, the higher your mortality, right up to the older stage. So it goes right through the life course.
Can I ask you specifically? You mentioned Fairer Lives. You published in the Marmot review. You published in 2010, and then the follow-up in 2020. And within Fairer Lives, you made a recommendation, particularly about a minimum income for healthy living. What role do you think our social security system has to ensure that?
Well, so I think we probably said it in my reviews, but certainly my general view of the evidence is that work is far preferable to non-work, if that's possible, for people. But it's got to be reasonable work. We said back in my 2010 review that the experiment of getting, for example, single mothers into low-paid, insecure, poor-quality work was a failure. That was not a social success. So trying to get the most disadvantaged, deprived people into the work that I've just characterized is not a social success by any means. So it's got to be well-paid, decent, quality work. We know the majority of people below the minimum income threshold are in households where at least one adult is working. So that's of working age. So work's got to be the way out of poverty. So work has to pay. For people who can't work, then the state has an absolutely vital role to play. We know for working age people, Joseph Rowntree Foundation and the Trussell Trust have calculated the cost of meeting essentials, and universal credit pays about 70% of the minimum income for healthy living. I was just looking at figures for pensioners, and with pension credit top-up, let's take a married couple, I think it's around £17,400. The estimate is, before housing costs, a pensioner couple would need about $22,000. So the amount of money they get with the pension credit is about $4,500 less than before housing costs than the minimum needed to have a healthy life. Then you've got to add housing costs on top. So the welfare system has an absolutely vital role to play, but it shouldn't be consigning people to incomes below what's needed to have a healthy life.
Michael, thank you so much. I'm going to hand over to Amanda Hack.
Thank you. I could listen to you all day. This is fascinating so far.
Better stop me, otherwise you might.
I think, so I served on the public, we did health in Leicestershire, public health, and even in Leicestershire, life expectancy has plateaued, but actually healthy life expectancy has really taken a dive. But in your work, you did put a course of optimism through that, particularly on main lessons from the Marmot city regions, like Greater Manchester. So what do you think would be needed to roll out more Marmot places in the UK?
I mean, your mention of optimism, commonly I get asked, the world's going to hell, are you depressed and pessimistic? And I say no. I was in Liverpool last Wednesday when they declared themselves a Marmot city. I was in Cardiff yesterday where they reconfirmed they're going to make Wales a Marmot nation. We launched 3 Scottish Marmot places in February, and I went to Newcastle on the way back, and they launched Newcastle as a Marmot city. I couldn't be more upbeat. Yeah, I know that I've heard about that chap in the White House, that's got us all. I can't affect what goes on in the White House, but I couldn't be more excited by what's going on in community after community. It'd be quite helpful if government came in behind them. Quite helpful. And what's interesting, I know you want to ask me about money, and I'm not good on money, but what's interesting is none of the communities that have invited us in have said, oh, the cuts to local government funding have been brutal. They have been brutal, but none have said that's an excuse for us not to do anything. We're going to do the best we can with the resources we have. I said, and I'm sorry if this is a circuitous answer to your question, but when I was in Liverpool, I said, we need the Chancellor to reduce child poverty, but what you can do locally is break the link between child poverty and poor outcomes. And by the way, when I talk about child poverty, everything I say about childhood applies to the rest of us. Because if we have less poverty, we'll have less pensioner poverty, isn't it? If we have better social conditions, better amenities, housing, that'll apply through the life course. So, but when I said we need the Chancellor to reduce child poverty, what you can do is break the link between child poverty and poor outcomes. And the Citizens Advice Bureau said, no, we're reducing poverty. We make sure people get the full benefits to which they're entitled. We help people of working age get into work. So we're actually in the business of reducing poverty, not just breaking the link. And the fact that Wales has taken this on nationally, the fact that Scotland has taken this on nationally, there's another country that slipped my mind. It'd be quite good if England took this on nationally and comes in behind the initiatives that are happening locally, because they're really exciting. The key question that I ask myself all the time is, does it work? Are we making a difference? And now these are not vaccine trials, so we don't have a proper counterfactual. I can't give you a Lancet publication that I've written to show it works in Coventry. I don't really know what would have happened had they not been a Marmot city. But I can tell you that there are indicators moving in the right direction. So it's not the kind of evidence that I would call PACA evidence. But the indicators are good. Improving housing, that's going to be good for pensioners. Improving conditions for young people, reducing the number of 18 to 24-year-olds not in employment, education or training. It's slightly circuitous, but if there are fewer young people on the streets making trouble, then pensioners who are afraid to go out because of fear of crime, that will improve their lot. I mean, it's a bit circuitous, but in other words, they're improving communities, and the indicators are moving in a good direction, with all the caveats that I said. So I think it would be very helpful to say we've learnt from these Marmot places of how important cross-sector action is. This is not just for health and social care. This is for employment, environment, housing, income. It's for all the key sectors. And it's easier to get that cross-sector action at city level. I think it's a bit easier to do it in Wales and Scotland. It's harder just because of scale to do it in Westminster. But I think that's what's needed.
Yeah, thank you. That's been really helpful.
Jo Baxter.
Thank you. What resources might be needed to roll out Marmot places across?
Sorry, what?
What resources do you think might be needed to help roll out Marmot places across the rest of the United Kingdom?
Well, I mean, I'm not the Chancellor, so I can tell you what happened, and I'm sure you know that. Central government support to local government went down by 59%. Over the decade, because of the increase in council tax. The total spend by local government went down by 34% over the decade from 2010. And the more deprived the area, the steeper the reduction. I plotted life expectancy for every local authority in England and the subsequent reduction. So in 2010-12, and the subsequent reduction in local government spending power. The shorter the life expectancy, the steeper the subsequent reduction in local government spending power. We've got to change that. It's regressive. That looks like a policy designed to increase health inequalities. That's what it looks like. I can't believe that was the purpose of the people who designed that policy. I don't believe that for a moment. But that's what it looks like. That's the effect. That's got to change. We need a more equitable settlement at local government. I mean, I try not to be political, but when the former Prime Minister said, you know what Labour was doing? It was putting money into deprived areas. We're going to move it out of deprived areas into wealthier areas. Well, the effect is life expectancy goes down in deprived areas, health gets worse. I think that's got to change. So I can't tell you how much it will cost. And as I said, I'm not the Chancellor. I always argue from a health point of view. But from a health point of view, I'd like a more equitable, less regressive settlement to local government.
No, thank you. And I note that same need exists in Scotland as well, actually, because the same approach has been taken with respect to local government funding there. Just moving on to the next question. So your review called for an ambitious national health inequalities strategy. What do you think that should have as its objective for older people?
My overall approach would be to put equity of health and well-being at the heart of all government policy. So, as you can imagine, I got asked, what do you think about winter fuel payments? What do you think about the two-child credit? What do you think? You can guess the questions that journalists wanted to ask me. And my response, in a way, to all of it is put equity of health and well-being at the heart of all government policy. That whatever it is you're deciding, and I know we don't do that when we decide to support Ukraine. And I think it's right that we support Ukraine. I'm not against, we don't do that. And we don't ask about cost-benefit analysis either when we support Ukraine. We only ask about cost-benefit analysis if we don't want to do something. oh, you want to spend more on supporting older people. What's the cost-benefit analysis for that? That, in my experience, you get asked that when they don't want to do it. If they do want to do it, they don't ask the cost-benefit analysis. I'm not against trying to do that analysis. We need to know if we're going to spend £1, are we better off to spend it here or there? And that's a reasonable question. But my overall put equity of health and well-being at the heart of all government policy. And you may decide that isn't the number one that you're going to do as a government because you've got other priorities. But that's what I would like to see.
Thank you.
Amanda Hag.
Thank you. I wanted to focus on the health 10-year health plan, but specifically in my constituency, we had most of the Leicestershire coalfields, and what we see in my health data is very much increase of COPD, but also increase of cardiovascular disease. So what should we prioritise looking at the 5-year plan for older people? I know in my constituency it would be that, but how would we do that more broadly?
So I'm in a slightly difficult place here because when people talk about prevention, they usually mean healthy lifestyle, not smoking, doing something, and I'm fully supportive of all those things, of course. But for me, prevention has got to be on the social determinants of health. It's got to be about housing. It's got to be about being able to afford to heat your dwelling. We did a report early last year, in from the cold. We said 1/3 of households in the United Kingdom are either below the minimum income threshold and in dwellings that are not up to energy conservation level C. And that, of course, includes pensioners. And it'll damage children's lungs and their mental health, and it will cause excess winter mortality in older people. So I'm not against doing something about lifestyle and smoking and diet and all of those things, of course, very important. But I want to do something about housing and having enough money to live on. And social isolation. I'm sure you know the figures, that social isolation is as deadly for people 50 and over as smoking. So social isolation, well, you might ask, what can government do? Well, local government, voluntary and community sector, supported by central government. I talked about fear of crime. We know, going back decades, when public transport was made free at the point of use for older people, they went to visit their grandchildren. They got on the bus. Yeah. So you can do things. I can remember being harangued by some economists saying, when I recommended in a report subsidising transport for older people before it had happened, and this economist haranguing me in the street saying, what are you doing, wanting to waste public money on old codgers like me, supporting Trump? Well, I think it's quite good if older people can go and visit their grandchildren because they can catch the bus. So we can, and to make it easier to get on the bus, so there's not a step up if you're a bit disabled. So there's a great deal that you can do to support the lives of older people. So I'd like to see in the 5-year plan, the first 5 years of the 10-year plan, absolute commitment to action on the social determinants of health.
I think that was fascinating. I mean, the data says, social isolation is like smoking 15 cigarettes a day in terms of the impact that has on people. You mentioned in your response to Joe, you've been asked all these questions, but what health impacts have you seen from the change of the eligibility to winter fuel payment? Have you researched that yet?
I can't quote you any figures yet. What we know before the changes, what we know, I mean, when the war in Ukraine broke out, we'd been saying that fuel poverty was around 10-15%. It looked like it was going to be 2/3 with a steep 2/3. So, so you've got to put the cut in subsidy to winter fuel payments in that context. And there's another point, which is, as Debbie knows, as the chair knows, we talk about proportionate universalism, which is a way of trying to combine the typical means-tested benefit approach with a more universal approach. Now, if 2/3 of households are facing fuel poverty in winter, then some kind of means-tested benefits won't work. Proportionate universalism, I think, is entirely consistent with some kind of tapering. You don't say, right, you get a benefit, you're eligible for pension credits, we'll give you the benefit, you get some other things, but everybody else, forget it. I mean, given that the figures are that if you're on the level of income that the pension credit tops you up to, that's not enough money to have a healthy life. So if you're between the amount of money you need for a healthy life and the level of income that the pension credit tops you up to say, well, you're not going to get a winter fuel payment. We know you're going to suffer, but we're not going to give it to you. Surely there must be some way of grading that.
Thank you. Thank you.
John Mill.
Thank you, Chair. As you know, the pension age is being pushed up steadily over a period of years, and it's going up again next year from 66 to 7. That's fine for some people, like MPs, who can work in long past senility, but not for everyone. So what mitigations or measures do you think the government could take to help those people who are going to be left out, a gap between their last job and their first pension?
Yeah, I mean, figure one in my Marmot review from 2010, for medium super output areas, for neighbourhood level of deprivation, we had two graphs, life expectancy and disability-free life expectancy. And we drew two horizontal lines on that graph, 65 and 67. And because of the social gradient, we said, if you advance, this is back in 2010, pension age from 65 to 67, 2/3 of the population, the more deprived 2/3, will not have disability-free life expectancy as long as 67. If the effect is to move people off pensions onto disability benefits, that'll have very little social value and won't save much money. Now, I don't know the figures of the, whatever it is, 2.8 million people in receipt of disability benefits, what proportion are in that 65 to 67 little band. I don't know those figures, but they must be available. But we predicted that you would get an increase in disability because people couldn't work that long. And if you look at the life expectancy figures, it's not as dramatic as for the disability-free life expectancy. But what we're doing is saying, you work all your life, but we're not going to give you a pension for very long if you're relatively deprived. So you just don't get it. You can work, but then you've got this much shorter period where you get a pension because of your shorter life expectancy. Going back to Adair Turner's report, he said that three possibilities of dealing with the problem. You work longer, you're poorer as a pensioner, or you pay more as a working age person. So we can solve it one way or another. The problem with working longer is the inequality dimension. That because poorer people then work longer and then enjoy a pension for less of their lives. And that's a social decision that we have to make as a society.
You're not making any specific recommendations for mitigations beyond not doing it?
Well, I mean, I would say that everything that I recommend in terms of action on the social determinants of health are trying to mitigate that. We're trying to prolong people's healthy lives. We want them to have longer lives and more of those lives spent in good health. I mean, that's the Holy Grail. That's what we're trying to do. And the evidence is that that has to be possible. I mean, I used to cite figures. If you go back to the 1960s, look at the social gradient in life expectancy in the 1960s. And if we were having this kind of meeting, we'd say, well, you know, what can you do about this? I mean, we've always had these inequalities. The life expectancy of the best off people in the early 1960s is now no better than that of the, not quite the worst off, but near the bottom now. So we've improved things dramatically for the poorest people. Dramatically. It's really possible to make these changes really quickly. Well, relatively quickly. So we can do it. It's not that it's impossible. I mean, it takes a while. But we can do it. That's what the evidence shows. I think we need to look a bit more Nordic. I was invited by the Norwegian Prime Minister to do a review of health inequalities in Norway. And, you know, I'm so used to making presentations where I say, oh God, this has gone badly and that's gone badly and this is doing well. And I'm presenting the report to the Norwegian ministers to say, actually, you're doing pretty well here and you're doing pretty well there, and that looks good. Now, they want to do even better because they've still got health inequalities, but they're narrower than ours. They look a good deal better. So take action on these social determinants of health. That will mitigate that problem.
Thank you.
Thank you. Jill German.
Thank you, Chair, and I couldn't be more delighted for you to join us today, so welcome, Sir Marmot. I wanted to talk to you about cliff edges in the social security system, and you have touched on this actually in one of your previous answers. So we know that we've heard concerns that there are people who are a few pounds above the threshold, and then that means that they miss out on thousands of pounds of passported benefits. So, for example, somebody with a small occupational pension, it means that they wouldn't be eligible for pension credit. My mum is one of these people. She had a job in retail. She's got a very modest pension, and it actually means that she's not eligible for an awful lot. So I wondered what kind of change that you think the government should take to this, and you've mentioned tapering, so if you think that is a way forward.
I think tapering is a way forward. I mean, I've been thinking about it more below pension age, of getting people into work. As you said, I mean, some of us keep working beyond pension age because we're privileged to have fulfilling work that's life-enhancing and the like. Thinking about fulfilling work, I was a colleague of mine in the US was originator of the Experience Corps and getting pensioners essentially to mentor teenagers, and very fulfilling for both sides. These teenagers from deprived backgrounds had an older person who cared about them. They could talk to, related to them, had time for them. So thinking creatively about what a creative role for older people could be. Don't know about your mum, but you know, being in loco grandmotherous, forgive my Latin, but, you know, to be somebody's grandma, somebody's mentor. I mean, to think more creatively about how we can say, well, you're on the scrap heap and we'll give you a bit of money till you die, and that's it. Or to say, no, we try and think creatively about a social role for older people, how they can use their wisdom, experience, humanity in a positive way that's fulfilling all round. So forgive me if that sounds a bit airy-fairy, but that's the way I'd like to be thinking about it.
Thank you, and a woman with 5 grandchildren of her own may find that she's a little overstretched on that front. But yeah, I take your point that you know, that there is huge benefit to be had. I've spent my life working with children and young people, and absolutely, this, you know, that dual benefit is something we really need to be exploring. So thank you, and your thoughts on tapering earlier as well. Just very briefly. I've been doing some work with local benefit advice agencies to try and increase the take-up of pension credit for those who are eligible, because many aren't aware of the process of what to do, etc. And I know that we've seen some success with that nationally, which is really positive. Your 2010 report referred to the patchy provision and short-term funding of advice work generally to support benefit take-up, and that's something I hear on the ground as well when I work with my local agencies. So what sort of change would you like to see here? I suspect your comments on local government previously may come in, and I'm totally in agreement with them, but I'd be interested to hear your views.
I have to put in a plug for the voluntary and community sector. I used to think, well, either government should do it or individuals should do it, and that was it, or the private sector. And then I realised that the voluntary and community sector are not just filling in the gaps. I quoted Citizens Advice Bureau a few minutes ago. They have an absolutely vital role to play, particularly in this issue of pension take-up. In Liverpool, the doctors write prescriptions to the CAB. So a patient comes, the doctor says, oh, you need to see the CAB. It's a kind of social prescribing. And they go off to the Citizens Advice Bureau. So to recognise the vital role that the voluntary and community sector has in doing something like making sure, helping people. We were, in the few minutes you kindly gave us outside, we were talking about pension credits, and I won't try and reproduce the conversation. How does this work? No. We think it would. No. How does it work? I think, bloody hell. We were the experts standing outside the room trying to make sure we knew how the pension credit system worked. Yeah. And we were, so I don't want to embarrass my colleagues. But then we thought, if we can't figure it out, and I'm sitting there looking at my iPad, and so I think the voluntary and community sector has an absolutely vital role in helping people.
Thank you, and that joined up working is certainly something I support as well, so thank you so much for that.
And that concludes our questions to you, Michael. Thank you so much for joining us today. We're going to take a short break. Order. Order, and welcome to our second witness for the self-evidence session for the Pensioner Poverty Inquiry. And it's a pleasure to welcome Dr. David Attwood. David, would you like to introduce yourself?
Hello everyone, my name's David Attwood. I'm a GP partner at Pathfields Medical Group, which is a 30,000 strong GP surgery in Plymouth, rural coastal deprived city. And I'm also the Associate Medical Director for Livewell, which is the community services arm of the health providers in our patch.
Well,
thanks for having me.
No, thank you for joining us. And I'm going to hand over to Steve Darling.
Thank you. And it was good to have a brief chat with you outside this room, and thank you for trekking up here. It was just, clearly your practice has, Plymouth is very urban, and then equally that level of rurality. It'd be really helpful if you could unpack that pensioner poverty and that dichotomy that there may well exist between urban pensioner poverty and that rural.
Thank you. I think the key thing, as part of answering that question, if I may, I think the key thing is drawing it back to what do we really want as a society. And I would argue that we would want our older population to live longer, healthier and more independent lives. And to do this, when we think about people's natural lifespan, the human body, it should enjoy a normal lifespan whereby your health does not impact on your independence. That is a normal lifespan. What we see, particularly in deprived areas, is that people don't age normally. They seem to show signs of almost accelerated aging, more rapid aging than an age-matched counterpart in a more affluent area, with cumulative loss of health and that eventually impacts on independence. And many of us in this room can be authentic citizens here, because we probably know family and friends that are on this journey. And it might start as a slowing up in life, where you walk a bit slower. The weekly shop takes a couple of hours instead of 1 hour. As things advance and your health deteriorates, your independence is affected, you might become housebound or in care home, needing carers to support with personal care. We've got a medical diagnosis that describes this accelerated ageing and loss of independence. It's the medical diagnosis of frailty, and it exists on a spectrum, mild, moderate and severe. Now, I'm going to use that word quite a lot, and I'm really keen to point out from the get-go that I use it as a medical diagnosis, not as an adjective. It's incredibly pejorative and discriminatory as an adjective. Why am I talking about frailty, and how does this relate to poverty? Well, the outcomes for frailty are grim, both for the individual and their loved ones, and also for the wider NHS. We know that the 1-year mortality for frailty rivals some of the most some of the most aggressive cancers in the UK. And we know that in terms of hospitalisation, we know that 50% of hospital beds are occupied by over 75s. 3 in 4 of them will have the medical diagnosis of frailty. If you're over 75 and hospitalised and you're not frail, your chance of dying in that hospital bed on that very admission is 1 in 50. For mild frailty, it doubles to 1 in 25. For moderate, it's 1 in 17. And for older people with severe frailty, there's a 1 in 5 chance of dying in that hospital bed on that very admission. If you are lucky enough to escape hospital, there's a 1 in 7 chance of being readmitted 28 days later to revisit those same statistics. We know that 2 in 5 over 75s are in their last year of life. And we know that a third will spend more than a month of that precious last year stranded in a hospital bed, often not by choice. Now, this is not the same as saying that hospitals are bad and they're to be avoided at all costs, and I certainly wouldn't want the committee to go ahead with that. If my mother's got a broken hip, I'd really like her to go into hospital. But what we'd like to do is we'd like to maximise the benefits and minimise the risks of our older population from a hospital admission. The costs of frailty to society and government have never been fully calculated. But let me give you a few numbers to play with. We know that the Department of Health and Social Care's annual budget for the last financial year was £188.5 billion. We know that all 42 integrated care systems in England are in deficit with a combined total of 1.5 billion. We know that just under half of that total spend goes on workforce. And we know that workload and workforce match. And when it comes to frailty and workload, it accounts for 39% of total hospital bed occupancy, 58% of total ambulance call-outs, 25% of primary care workload, I would estimate, based on lived experience, and it will dominate the adult social care budget. The cost is unfathomably massive. And whilst we're thinking about that cost, let's spare a thought today for all the individuals and their loved ones that are in hospital right now, powering those tragic statistics. And this is happening in the 21st century. And the good thing is that everyone in this room, we can all be authentic citizens here, because we will have no friends, no loved ones either on this journey at the moment or powering some of these statistics in the past. So that's why frailty matters. When what we need to do, if we want to achieve our goal of having a society of healthy ageing where everyone has the opportunity to enjoy a normal lifespan of health and independence, we need to absolutely make frailty rare. And we need to do this by preventing the development of frailty and halting, delaying, or reversing established frailty. Now, when it comes to causes of these things and things that we can target, deprivation is absolutely front and centre stage. Poverty is a big contributor to the development of frailty, and I won't repeat what Sir Michael Marmot said. I agree with everything he says about wider determinants of health. The only thing I would echo is that people from a deprived background face a cumulative disadvantage throughout life because of inequality. And they will consult with their GPs much more frequently. They will utilise healthcare much more frequently. And I would say that the funding for NHS spend does not accurately reflect inequality and deprivation. And that does need addressing. The other thing I would say is that when it comes to there are other factors, despite deprivation, that are associated with the development of frailty. It's more common in deprived communities, but it can occur in more affluent areas. Things like loneliness, social isolation, bereavement, loss of a loved one, physical inactivity, mental health, chronic pain, individual factors, smoking, alcohol, nutritional choices. And there'll be other factors as well that I've submitted. An area I'm quite interested in is what is it about the individual that takes all of those factors and makes decisions based on that? So, for example, if you are from a deprived background and you're an older pensioner and you've got a cigarette in your desk, some people will say, that's my only luxury in life. I'm going to carry on smoking. I'll spend my tiny budget on this habit. Others will say, do you know what? Maybe I could escape nicotine addiction. Maybe I could focus a bit more on my health and some of the budget could be used elsewhere in my household. Those individual choices are areas that are ripe for intervention. It's called behavioural change theory, and there's loads of and people from health, social and voluntary sector can be trained to manage behavioural change theory. So to bring it back to where we are, in summary, I would say we would like to have a society that where we see healthy ageing. To do that, we need to make frailty rare by preventing it and reversing, delaying and preventing progression of established frailty. And I think if we target all of the determinants, then we will have a really healthy older society.
Thank you. I did ask at the beginning about, is there a dichotomy between rural and urban, because in your introduction you did talk about being rural and urban covering your patch. Is there any of that, or is it mostly just inner city Plymouth the challenge?
It's a good question, Steve. If I'm honest, we're mostly in a city, so I can't comment so much on rural areas. But what I will say is that rural areas face their own individual demographics and challenges. You know, it's a much wider population. Often, I suspect other factors will be at play.
That's really helpful. And your focus on frailty, I'm sure colleagues would have found that really helpful. I really wanted to understand, and the impact on the health service and social care is probably a bit of a given from what you were describing, but Professor Marmot was highlighting the opportunities of the voluntary sector. You know, can you unpack that a bit? And I know not too far away, my constituents at Toby, we've got a really active ageing well approach, you know, in the voluntary sector. You know, is that part of your world in Plymouth? But also, where are there other opportunities? I know, for instance, Plymouth Argyle could be doing stuff with over 55-year-olds to be more active and stuff like that. So, you know, can you pick that bit of your world of how there could this broader approach rather than just think it's health and social care's problem?
Steve, I'm delighted that you've said that, and I certainly wouldn't want to leave this room without you thinking that I really value our voluntary and community sector. We wouldn't be where we are without them today. They really are fabulous. And in terms of where we are with things, in our patch we've implemented an, if you like, command and control older people's hub with an integrated neighbourhood team, and it brings professionals from health, social and the voluntary community and social enterprise sector together as one big shared team. And this shared team works on a shared IT solution, and it delivers a single shared biopsychosocial assessment that targets all of the things that will lead to the development of frailty or allow frailty to progress if unchecked. And these three ingredients, the shared health social VCSE teams, shared IT solutions, shared single assessment, which is based on a comprehensive geriatric assessment. It's a bit of a mouthful, we call it CGA for short. It's that biopsychosocial assessment. Those three things together, I believe, improve outcomes for older people. We have data for that now. But also working together, we leverage the benefits of continuity. And continuity has been independently associated with better health outcomes. And then, so we've got four ingredients. The fifth ingredient is our teams are loaded with advanced digital tech, so we can better identify individuals with frailty. We can pinpoint ones within frailty that are at higher risk of progression, and we can send teams out to target them for holistic interventions that can improve patient outcomes and, as I say, prevent delay and reverse frailty. So there's those five winning ingredients, if you like. Will you permit me to talk a bit more about health outcomes and what we've found? Is that?
I'm sure we've got lots of questions. Yeah. I'm sure if you can be brief, it'd be really helpful.
Okay. So in a sentence, we have published a mixture of data showing that older people, there are outcomes showing that they may be living longer, despite being in a deprived practice. They may be living healthier with a reduction in frailty prevalence and severity. And we're also seeing reductions in healthcare utilisation. The 25% reduction in A&E admissions in over 75s, comparing this year with 2019, so pre-pandemic, and a 41% in its sustained reduction in unplanned care home admissions over the same time frame.
Thank you.
Thanks, Steve. Frank McNally.
Thank you very much, Chair, and David, appreciate your contribution this morning, and you have touched on some of the challenges and the consequences linked to frailty. Certainly in Scotland, we have seen, really the failure of an effective joined up approach to addressing some of these challenges, particularly with the challenges linked to health and social care. We had a Healthcare Improvement Scotland report last year highlighted that at least 10% of Scots over the age of 65 are recognised as frail, but 42% are recognised as being pre-frail, so obviously a significant risk, and we know by 2035 that over 65 population is going to be more than 30% of the population in Scotland, so we can see the potential difficulties coming towards us. You have touched on my first question in response to Steve, really around that was really focused on the evaluation of the work that you've been doing and the impact that it's had on older patients. But I mean, you've mentioned some of the key outcomes here. Do you want to expand on that at all?
Yeah, I think that thank you. I'd be delighted if that's all right. I think the key thing that we've been focusing on is maintaining that razor-like focus on a healthy older population. Because that's the only thing that really, really matters. Because healthy people will have happier lives, and that's got to be the purpose of the NHS, and will naturally utilise healthcare less. My favourite graph this year, if you could put such a word in a sentence, was a time series graph looking at frailty prevalence in our over 70s population. And since 2021, we've seen progressive year-on-year reductions in people with moderate to severe frailty. And although we've had growth in our older population, that growth is driven by people that are fit and well and have mild frailty. So, Frank, there's hope for you guys in Scotland. There truly is. And if we get the balance right and we maintain that razor-like focus on health. And when you think about it in terms of triangulating the statistics, it kind of makes sense, doesn't it? If you focus on health, you should see less frailty. You should see more fit and well people that are ageing well. If you focus on health, you are less likely to need to utilise hospital. We are seeing that in our older population as well. But we're also seeing improved survival as well. We've published, and it's been independently peer-reviewed and published and presented at the British Geriatrics Society autumn meeting last year, data on 429 residents in care homes, showing an absolute 2-year survival advantage of 39.6%. So our older people are living longer, but healthier as a result. And hot off the press yesterday, I didn't have the chance to submit it. I'll submit it retrospectively to the group, and I'd like to credit a colleague, Dave Spencer, who's in that Devon ICB with analysing this data. He's shown that he's produced a graph looking at deprivation on the vertical axis and mortality per 100,000 along the horizontal axis. And you can easily imagine, can't you? The more deprived you are, the more likely you are, the higher the mortality is going to be. Our surgery is one of the most highly deprived surgeries in the Devon area. And we have an under 75 mortality that is comparable to some of the most affluent areas. Most of the deaths occur in the 55 to 75 year bracket, so it's preliminary data, needs a bit more unpacking, but the ICB are very, very excited by this data because it seems like we might be beating deprivation, which is quite nice.
So, I mean, I suppose just expanding on that, you've cited a whole range of welcome outcomes there in terms of the work that you're doing. Do you see any particular challenges around upscaling, trying to see the work that you're doing go beyond the areas that you're covering just now? And I suppose just one final question would be around the priorities of government. So ultimately, we are keen to get a sense of if there are any areas where you think the government should be prioritising in terms of improving health ageing for people in later life.
So in terms of upscaling, the formula, the 5 winning ingredients, if you like, are of shared teams, health, social, VCSE, shared IT, shared single assessment, continuity, and my mind has gone blank on the 5th one, which I said earlier, referred to earlier on the meeting. They are all scalable. It requires some time. There is a certain methodology to do this, but this is all eminently scalable. It is But we've been doing this now for 6 years, so it takes a little while as well to see the data emerge, and I would urge government to be patient, but to just know that it will work. So hold your nerve, Frank, when you go back to Scotland and have a chat with the various folk there. Tell the team to hold their nerve. The biggest challenge we face is actually all of the stuff that's taking place, all of the chaos that's taking place out with of our community. It's very, very difficult to keep this model going because of a variety of national and local policy drivers. And I would say that in terms of things that could be done to really, really help embed this, number one, it would be our focus is on health and independence and the wider determinants of that. It would be lovely to have a long-term plan for healthy communities that's put out by all parties. And all departments in government should be signed up to this and engaged with all stakeholders on this. It's not about health, it moves wildly beyond that into all departments, because we all have a role to play in developing a healthy society. That's number one. Number two, that long-term plan needs to follow a natural life course approach of children and young people, working age adults and older people, because those groups have slightly different and more nuanced needs. Number three, when it comes to doing that plan, it should address two NHS cultural issues head-on. Number one is our enthusiasm in the NHS. I don't know what other departments are like, but our enthusiasm for developing plans in the NHS is not matched with an enthusiasm for executing the plans. And so we have a proliferation of plans and very little in the way of absolute change. And I would like to see the last plan as a living document that every government can update in light of the latest information. We adhere to that plan, we implement that plan. Next thing, in the NHS, it was set up in 1948 to offer high quality healthcare for free, for all, forever. The 21st century NHS is subtly different. It feels sometimes like a national hospital-centric service where policy has been driven by getting people out of hospital at all costs, because hospital beds drive NHS spend. And as a result of that, policy often has led to many penny-rich, pound-poor strategies focusing on discharge and avoiding admissions at all costs. That is not the same as a razor-like focus on health and improving health. We all service our cars proactively and regularly to keep them healthy so that they will last us longer and not cost us loads of money when they're 10 years old. We need to adopt the same pattern with the NHS and go back to focusing on high quality health for all, for free, forever. And when it comes to that, we do need to think about deprivation, and we need to ensure the funding moves from sickness to prevention, hospital to community, analogue to digital, and affluent to deprivation, I would say, as a fourth, because it doesn't accurately reflect the challenges of deprived communities. Other things to...
Final thoughts, if that's all right, David.
Yeah.
Okay, thank you.
Final thoughts are, I would like to hope within this evidence given that we've shown that primary care, general practice working with wider health, social and VCSE colleagues can deliver. I think the challenges that we're facing, particularly in general practice at the moment, are ones of the national insurance pension contributions. In my surgery, we are looking at 120 grand's worth of extra increase in NI contributions. On top of that, we have the top-ups of our staff to minimum wage. We used to be a real living wage employer. We are no longer. We can't afford it. When we top up those staff, we have to uplift the other staff that manage them so that the salary increment can be the same. So everybody needs uplifting. We also will have the increased costs of goods because all of the other private sectors, things like heating, etc., will all go up because they're all paying their NI contributions, and that cost is going to be passed on to the end user, which is me. When you are in a situation where you are faced with a fixed budget, you have one option, well, two options. You can go bust or take a pay cut, or you can cut output. And with the situation we're in now, with 125k of increased NI contributions and the rest that I've outlined, realistically means that the extra money that's going into general practice is coming straight back out and boomeranging back to the Treasury. In real terms, the GPs that are leaving for good reasons, family reasons, or one of them's going back to Scotland, she's fabulous, Steve will miss her Frank will miss her dearly. We are not replacing those GPs because we don't think we can afford to. Ask us in 12 months' time what the finances will look like. And it's worth noting that we are NHS and are exempt from those contributions.
Thank you so much, Dr. Attwood. Really pleasure to have you with us here today. We're going to have a quick break. Order. Order, and welcome back to the Pensioner Poverty Inquiry and our final panel for this morning. And we have David Finch, Ruth Law and Toby North. Would you like to start with a brief introduction, David, and we'll go down the line?
I'm David Finch, Assistant Director in the Healthy Lives team at the Health Foundation, which is an independent charity working to improve health and reduce inequalities.
Hello, I'm Dr. Ruth Law. I'm a consultant doctor working in North London. I work in hospitals and in the community. I'm here on behalf of the British Geriatrics Society. We're a membership organisation, and our mandate is to improve healthcare for older people. I'm Vice President for Policy there.
Morning, I'm Toby North, Head of Public Affairs at Marie Curie. We are the largest and leading end-of-life charity in the UK. Here for anyone with any illness that they're likely to die from and those close to them. We take a very holistic view of what good end-of-life care looks like, including both physical, emotional support as well as practical support, such as including ensuring people have their material needs met at the end of life.
Thank you. So I'm going to kick off with questions, and other members of the committee have questions as well. So you probably heard from the other panellists as well. So I wondered, from your point of view, what you think to what extent ill health for older people is due to their earlier life experiences or down to the ageing process. And I'm also very interested if you could include that in your answer and how poverty impacts on age or the ageing process. Who wants to kick off?
I'm happy to.
Okay.
So, in answer to the first part of your question, I think it's generally understood that about 25% of how we age is genetically predetermined. That's the figure that's usually quoted. So there's quite a large potential for influencing ageing well. And I think, as the CMO report in 2023 about the Ageing Society showed, if you're wealthier, you'll not only live longer, but your years in ill health are shorter. So that's really what we're aiming for the whole population, is to manage those risk factors in that 75%, so that people can have fewer older years in ill health. There are lots of things that contribute to that, many of which are not expensive at all, but lots of which are contributed to by poverty. So the commonest things we would recommend to people who are trying to age well are around physical activity, however small an amount each day. But we know about half of people over 75 in the UK aren't physically active, so are moving for less than 30 minutes a week in a very active way. Social contact, which has already been mentioned. Loneliness hugely contributes to ill health through social disconnection, also affects people's cognitive development if they're not interacting regularly with people. And about 4 million people over 65 are living in single occupancy households in the country, and the majority of those are women. And then also the things that have been mentioned around following a healthy lifestyle, so choices around nicotine, alcohol and food. Age UK have found that 1 in 5 older people are having to cut back on food and groceries at the moment, for example, due to pensioner poverty. So I think the message really is that living in poverty makes all those things harder. I mean, just a simple example, some of my patients like to go down the cafe to have their lunch, and if they haven't got enough money, they're no longer doing that, and they don't realise that means they're not getting their daily walk, they're not getting their daily social contact, and they're also not sitting in a warm place. So it's actually quite basic things that can contribute to that 75%, I think.
Okay. David, do you want to add to that?
Yeah, sure. So, I think for us, poverty is absolutely shaping kind of people's health through the lifetime. Even kind of short periods of poverty when people are young can affect their health and health through future ages. And I think, as we've heard a little bit before, kind of over the lifetime, these factors can interact. So if you have lower income, then you're less likely to have good health, and that can also affect your ability to earn or work, which means you can have this kind of accumulation over the lifetime of worse health and worse outcomes. It's probably most easily kind of described in the deprivation gap in healthy life expectancy, where there's an 18-year gap between how long a person living in the most deprived areas are expected to live in good health compared to people in the least deprived areas. And it also, I think, is kind of quite apparent where we've looked at diagnosed conditions, where a woman aged 60 in England living in the most deprived areas is likely to have has the same kind of health outcome as a 76-year-old living in the least deprived areas. So you can really see, I think, when you start to look at outcomes by a deprivation area, how that interaction with those kind of circumstances are affecting people's health over lifetime. I think for pensioners particularly, I suppose there are some specific challenges in the I think in an instance of a shock, as we've seen kind of with the cost of living crisis recently, pensioners are probably many pensioners will be less able to adapt their income to cope with that shock, and then also are perhaps more immediately vulnerable to some of the health outcomes that can come from that, things like living with cold or being unable to eat, which I think means that although those things will affect people's health at working age, it won't necessarily lead to as acute an instance of kind of healthcare need as it comes through. But I think overall, I think it's one of the sort of factor there is also the kind of increasing complexity of health conditions in older ages. So people at older ages are increasingly likely to have one or more than one health condition. So I think it's that interaction and to some extent perhaps inability to adjust over a sort of period of time to shocks that can really kind of make, I suppose, what are outcomes defined by people's lifetimes actually become much worse quite quickly in older age.
Thank you. Toby?
Thank you. So our focus is a lot less on long-term causation and a lot more on the immediate and significant financial impact that a terminal diagnosis can have on somebody, because we know that diagnosis can come with a lot higher costs for people and push them towards financial insecurity. So last year we commissioned research from the University of Loughborough, and we found that 88,000 pensioners, that's more than 1 in 7, spend the last year of their life in poverty. That's significantly higher than pensioners who are not in their final year of life, and 110,000 pensioners are dying in fuel poverty each year, highlighting that it's often energy costs which are driving some of those challenges.
So you mentioned pensioners who hadn't been in poverty rather. given an end-of-life diagnosis and they fall into poverty. So can you explain, is that because of changes in circumstances, not being able to work, or?
Largely it's because of additional costs.
Okay.
So whether it's paying for medication, travel to hospital appointments, paying for personal care that might be a direct result of their diagnosis. But the sharpest cost pressure we know is because of rising energy costs. And I think maybe we'll come on to talk a bit more about the impact of cold and energy costs later. But we know that things like needing to be warmer, being at home for longer during the day, but also needing to run essential medical devices which have quite high electricity needs can have a real impact.
Can I come back to you, Ruth, in terms of what we were talking about in the previous panel with Dr. Attwood around frailty and poverty, and I wondered if you want to, obviously Dr. Attwood was mentioning his own particular programme that his practice is running, but more broadly, is this a trend that, about the relationship with poverty and frailty that we're seeing across the UK, across England? Yeah.
So as I've already said, poverty makes ageing well harder, so you are more likely to be frail in older age. There was a longitudinal study on the impact of what we might call the austerity years, and it did show that the mean frailty score in the population increased disproportionately during 2012 to 2018 as opposed to the pre-austerity period. So there is certainly a suggestion that poverty is worsening frailty in this country.
Can I ask, the age group that you're looking at? So,
I mean, going back to what David said, that frailty as a sort of clinical term is usually referenced as people over the age of 65.
Okay.
Yeah. Okay. And about 10% of people over the age of 65 living with frailty, and then as you get up to 85, it's up to 50% of people. So, I mean, the good news is lots of people are not living with frailty. I don't want to be all doom and gloom about older age, but there's a big cohort of people that we have the opportunity to improve how they age. And I think that's sort of similar to what Toby's just saying. Living in poverty just means it's harder to access healthcare services, the transportation, any services that have charges associated, so particularly dentistry is a big issue, and the knock-on effects of that for older people in terms of nutrition, everything is sort of a domino effect. And it's just important to remember that older people are the biggest users of healthcare services, so if poverty makes you more likely to be frail and poverty makes it harder to access healthcare, then it's a sort of double whammy for older people, I think.
I'm thinking about, we also touched on the state pension age, and I think it was Professor Sir Michael Marmot who mentioned that, and the impact in living in disability-free years. How could that affect working, basically? Those that are living in poverty, that are deemed frail over 65, who are then expected to work, what would be the impact on that?
I mean, frailty as a condition can be categorised into mild, moderate and severe. I think it would be unlikely that someone who's severely frail would still be able to work. But it's the same as any long-term condition, really. As it gets worse, it impacts on your ability to contribute to employment and will definitely make working more difficult. Is that what you're asking?
It is, really, yes. I mean, that we are in the process of reviewing state pension age, going up to 67, but there are, whether that will increase even further, and we just need to recognise if frailty is something that is also...
And it often coexists with multimorbidity and physical disability. There's a huge overlap. It's already been mentioned, as people age, they accumulate more long-term conditions over time as well.
Thank you, that's very helpful. David Pinto-Duchinsky.
Thank you so much, Chair. Thank you so much for sharing that testimony. I wanted to focus my questions around poor outcomes for certain groups. Obviously, we see health inequalities across different ethnic groups, for instance. Would be interested to get your views on what's driving that. So, for instance, is that fundamentally a reflection of early life experiences and earlier life inequalities? Ruth, I don't know if you want.
Me? Okay. I mean, I know, David, you've written a whole report on this, haven't you? But
yeah. I mean, I think the short answer is it's very complicated. I think it's the and particularly because, I mean, to really understand it, you do have to, particularly if we're talking about ethnicity, look at specific groups and understand kind of lifetime experiences within them. So I think I don't think I would do it justice in doing a very short answer. We can submit the full report to you to explain it. I think what we do find is there are some specific groups who, well, I mean, at pensioner age, there are some groups who are more likely to be in poverty. So particularly, kind of Asian and Asian British pensioners and Black African, Caribbean, Black British pensioners are more likely to be in poverty than white pensioners. But I suppose part of the issue is in thinking about ethnicity is thinking about the change in population over time, which will also mean that I think some of that picture will change as different cohorts kind of age and come through the population. And I think so. It's quite important to think about. I think it's quite important to think about that within in thinking about I suppose how those effects might vary over time. We also know that there are specific parts of specific populations that are more likely to have certain health conditions. I think. Sorry, I don't have the precise. I don't want to get it wrong and give you the wrong wrong detail on the
yes,
ethnicity.
Don't feel under pressure.
But we can send you more detail on some of those different groups, which is I think really about looking at diagnosed illness within the population.
Yeah. But broadly, just come back to it. So I understand that's been really helpful. The trends are potentially changing. It's a complex landscape. But are there any things that you particularly pick out? Because I suppose relating back also to earlier conversations we've had, trying to get a sense of what's lying beneath that, and critically, therefore, what are the kinds of things that should be being done to address it?
Well, I think if we're particularly thinking about pension outcomes as well, then it will go back to kind of people's lifetime labour market experiences, and we know there that clearly there are sort of inequalities between some ethnic groups around earnings levels and kind of lifetime employment histories. And another factor for some will be, I suppose, ultimately migration, and when people have arrived in the UK to know how long they've had to build up kind of UK pension rights. But I think ultimately in trying to address, I think if you're worried about inequalities across ethnicity, often it's about going back to understand I suppose challenges and inequalities that they will have through the working life related to kind of employment outcomes, their earnings, and whether people are growing up in poverty as well.
Are there any other drivers that particularly speak to the health inequalities picture of that?
I think there is within literature and within some of the work we've been funding, like discrimination and access to services and treatment will play a role, and sometimes people's perhaps hesitancy in accessing services. I don't have anything on. I don't have detail on anything else beyond that. Very good.
Ruth or Toby, I don't know if you have anything to add.
Certainly, I mean, it's not national level data, but just from personal experience, there's a real problem with access to translation services. It just feels like the odds are stacked against people if they're not English-speaking, white British residents. They're often living in, more likely to be living in multiple occupancy households, which has impacts on health. It's harder to access the voluntary sector, and then sort of some of the cultural things that are being mentioned around access to healthcare as well. So it's quite multifactorial. It's what it needs, I think, is sort of locally led targeted interventions. I work in a sort of inner city area, and there's particular ethnic groups living in communities that we specifically approach, try and include in our focus groups in how we're managing access to the hospital, so that we're doing things in a way that people can relate to and interact with. But that's quite locally based rather than a national model. But I think that kind of approach needs to be happening everywhere, because the structures are such that it's really difficult for people to access healthcare.
Thank you.
Bring it back to people with a terminal condition. We know that there are particular groups that have massive inequities in access to palliative and end-of-life care. That tends to be people living in more deprived and rural areas, certain minoritised ethnic groups, as well as a number of other protected characteristics. And in terms of financial support, we know that, and also to mention that people with a non-cancer diagnosis also struggle to access good palliative and end-of-life care. That tends to be because there's a very clear diagnostic pathway for cancer that results in clear prognostication and an earlier assessment that that condition may be incurable. That means when we have special rules for the end of life within the welfare system, which rely on a terminal diagnosis of 12 months or less to live, giving you fast-tracked access to benefits, normally at a higher level, that means that for those groups that are suffering significant inequities, they also have a barrier to accessing the financial support they might need, as well as the clinical support through good palliative and end-of-life care.
Thank you. And Toby, that leads us neatly to my next question, which is, obviously we approach this with the lens of looking at minoritized communities, but are there other groups that particularly need additional support? You flagged up those towards the end of life. Are there any other groups that stand out?
Support in what way, sorry?
Well, in terms of health support, other things, exactly the kind of stuff the in the inquiry is looking at.
Excuse me. I guess we're specifically talking about. So I'm sort of representing older people as a whole, and I, from all the work we've done, I think the sort of health and social care system is not set up for them in general. I don't think it even is broken down into smaller minority groups. The system's just not internalised the fact that we have this ageing population and is not ready for the amount of the complexity that is coming. These people have already been born, and the statistics are already there. We can kind of see the graphs, but we need sort of frailty-attuned healthcare across the piece, and that would then have a positive impact for all groups of older people, I think.
Great, thank you. David?
Well, I think if we're thinking about poverty, then renters also are another group who tend to be at high risk of living in poverty, and so that, and we also know that kind of rented accommodation, particularly, well, at least in the private rented sector, tends to have lower quality. So there's a specific risk there for people who are pensioners who are in poverty, so more likely to have health conditions, and also living in the private rented sector, so more likely to have kind of higher housing costs. I think there is also, I suppose, because we're looking at poverty and health, there are other aspects to that. So I think if we're thinking about housing specifically, for example, it's actually home-owned houses that have, there are more home-owned houses that have that don't meet the decent home standard than other types of tenure. And actually there's an issue there where I think it can be quite hard to get people who own their own home to do things to do it effectively, whereas through the rental system you have more triggers in place where you can kind of look for moments where you can intervene and upgrade. So I think there's so renters is another kind of area to think about, and also particularly in possibly thinking about future cohorts and their ability to have kind of adequate incomes in retirement is, if when we look beyond kind of the current generation, you start to see some slightly lower home ownership effectively across those generations, and so you might expect greater challenges coming from kind of things like private rental costs into the future for some future cohorts.
Great, thank you. Toby, do you have anything to add? And so, look, and that brings me to my last question. I'm conscious of time. Toby, you call for the gap in support available for people with different diagnoses to be closed. What would that look like in practice, do you think?
I think key to that would be earlier identification of palliative and end-of-life care needs. I think also there is a need to look again at the special rules for the end of life. whilst they've been really welcome and they have enabled much greater support for people with a terminal diagnosis, people approaching the end of life, we do still see that there are many people who have a terminal condition and they are living with the increased costs that brings, but because they don't have a 12-month diagnosis, they are not able to access additional support. They're not able to access support at the higher levels. And so we would really encourage that to be looked at. There are we talked a little bit about the increased pension age and the impact that will have. And the reality is that the pension age benefits provide a much higher level of support than working age benefits, whether you have a terminal diagnosis or not. So we see much higher rates of poverty amongst working age people who are terminally ill. So really what we would suggest is that we need to see something like a pensioner level equivalent of income for people of working age with a terminal diagnosis. These are people who may have been paying into the system for their entire lives, but because they have got a terminal diagnosis and are likely to die before they reach state pension age, they really are forced to struggling to meet ends meet. So we would urge that to be something that's looked at, particularly as year on year we estimate that 7,700 more people will be dying every year the state pension age goes up. More people will be dying without access to their state pensions.
Great. Thank you so much. Yeah, thank you.
Thank you, David. I'm handing over to Danny Kruger.
Brilliant, thank you very much. A quick question for David and one for Ruth, please. David, just thinking about cold, is it easy to categorise the conditions in which people have that make them particularly susceptible to cold at home? And secondly, are you aware of work that's going on anywhere into the effect of the winter fuel payment cut on health outcomes?
So on the first question, it tends to be, I suppose, people with respiratory diseases and things like heart diseases that are most kind of linked into issues of cold, but also it can also worsen musculoskeletal conditions like arthritis as well. So I think those are particular, and I suppose you can quite possibly have people with a mix of all three of those conditions, particularly if you're looking at the older population. On the impact of winter fuel payments, I'm not aware of specific work that is ongoing there, but it's something that we're thinking about how far we could be able to look into that.
Well, just say a bit more about that. How easy is it going to be to try and analyse the effect of that particular policy on health outcomes, do you think?
Yeah. I think difficult. I think as we're actually trying to understand a lot of the health impacts of different kind of policy changes, often the fall down is the lack of linked administrative data. So, ideally you would have data that links people's health outcomes and their usage of the health services with things like their income, maybe their receipt of benefits as well. And I suppose you could also link in data related to kind of temperature changes, which is probably slightly easier actually to do. But I think where it tends to fall down is being able to link those two things together. But we have had a programme of work called the Network Data Lab, which is trying to support local areas to link up different bits of data from across the health and social system. It's just it can take time to get.
Do you think the data exists? It's a question of effective linking and access to it. Yeah. Okay. Well, I might pick that up. Thank you. That's brilliant. And then Ruth, rather general question for you. I was just struck by what Michael Marmot was saying earlier about the social determinants of health, and he referenced income and also kind of social infrastructure and facilities in the community. We didn't mention family structure at all. Have you got views on that? Is it possible to make effective analysis of the causal links between particular family types, between the kind of extent of extended families, the whole sort of relational component of health that isn't specifically about either income levels or sort of community provision, but is more particular to families?
I don't have data, but I'd certainly have views if that's okay. So I think first of all, thinking about the social contact that we've spoken about and the impact of loneliness, that would obviously be addressed very effectively if you're in a strong family or social network. I think a lot of older people talk about just feeling invisible, like they've disappeared from society. So I think that, and we know that lack of social contact is a risk factor for dementia in older life, for example. But also just that lack of encouragement to get out the house if you're on your own. I think the other thing that springs to mind when you speak about that is, and again, I'm sorry I don't have the data, but the amount of care that's provided in this country by unpaid carers, family members, the fact that our social care service is under such strain when actually a huge amount of care is given by this hidden population. And certainly, as you get into older age, it's often your informal carer is also an older person, and it's not a sustainable situation. So whilst there's positives, I think there's a real risk around relying on family to be the solution to some of the situations we're facing.
Yes, okay, great. Any other thoughts on that topic from my other panellists?
Just picking up that point from Ruth around unpaid carers. Unpaid end-of-life carers are a significantly under-recognised and under-studied group. We commissioned some research earlier this year, which attempted for the first time to put a number on the number of unpaid end-of-life carers that are people looking after someone with a terminal illness. And we found it was up to 750,000. But we also looked in detail at the financial impact of that unpaid end-of-life caring, which is significant, and it gets even worse after a bereavement. So what we're finding is that up to 15% of household end-of-life carers are living in poverty, but that doubles when someone is bereaved. So a response to that we're recommending is that the entitlement to carers allowance after a bereavement should be extended from 2 months, where it is, to 6 months, to give people a bit more of a cushion if they are in that position.
Yes, yeah, very helpful. Is it your suggestion that the care that's being provided by unpaid carers is just insufficiently supported, so we should be supporting, as it were, unpaid carers, we should be paying them a bit more, providing more generosity in the system, or that in fact they're doing work that should be provided by paid professionals?
The former. The unpaid end-of-life care workforce, although it's not a workforce, it's voluntary, it is absolutely vital, and we will need that to continue, but the reality is we need to support those people.
So it's a benefit system problem rather than a health system problem. Yeah, thank you. Okay, that's great. Thanks a lot.
Thank you. Steve Darling.
Thank you. I was going to, a significant part of mine was around winter fuel, but it's already been picked up by the previous colleague, so I'll leave my question as it's already now being covered.
Okay.
Just on that point, we actually did some work looking at the number of terminally ill people who would have been eligible for the winter fuel payment, who are, after the changes, were not, and we found that there's 44,000 pensioners who were receiving benefits, disability benefits, through the special rules, who would no longer be eligible for the winter fuel payment. That's a huge number, particularly given what I've already set out in terms of the particular challenges around energy costs for people with a terminal illness. So that is something we would really urge the government to look at moving forward, and to consider that a particular group that needs that additional energy support.
And over to John Milne.
Thank you. There's been a lot of talk about moving to a more preventative approach to health. What do you think the main challenges are to taking that path? Toby, if you want to start.
In the context of good end-of-life care, it's that early identification of palliative and end-of-life care needs. We might assume that terminal diagnosis is quite a straightforward process and people understand what that palliative care journey looks like. But the reality is we're actually very bad at having conversations about death and dying in this country, and that extends to advanced care planning with care professionals, discussions with people's families, and also those other advice and support services which may be able to help. So at Marie Curie, our information and support advice lines, money troubles are one of the most frequently raised concerns before often clinical concerns. A real concern we've got at the moment is that recent changes to the GP's contract has removed the requirement for GPs to maintain a palliative care register. So that removes one of the main incentives for early identification of palliative care needs, which is very concerning. And we hope that will be addressed in some other mechanism through the NHS long-term plan.
Thank you. Ruth?
I think the more I see patients in their homes, the more I'm humbled by the fact that really my intervention as a doctor is not the biggest thing that's going to make them well. And I think often it's quoted about only 10% of health is contributed to by healthcare itself. So this big prevention agenda is so important. The wider determinants of health, they just don't have enough focus But for frailty, I think it's similar. You know, it's recognising it early. Using the electronic identification systems we have in patient records to pick out those people and giving them access to things that help them age well and stop their frailty progressing. And those things are not really things that come from doctors and allied health professionals. They do come from support of the voluntary sector, lots of things that the local authority are doing, and that's where we need to be, well, all the things that Sir Michael Marmot was talking about really in terms of the wider determinants of health that keep people well.
Thank you. And David, same question, but if you could also think of it in the context of, you know, what returns or benefits might the government see from such an approach?
Sure. And we tend to think about prevention as well in a slightly broader sense in thinking about kind of wider determinants of health, and I suppose ultimately taking actions that will prevent acute need arising. And I think when we've, I suppose, beyond perhaps what can sometimes be kind of political challenges around kind of sometimes short-termism in policy making, and I suppose also kind of putting the current fiscal position to one side to some extent, which maybe is too easy to get at. I think I think things that we are thinking about and tend to consider. I think one thing is actually we don't really measure what we spend on prevention in any meaningful way, and it's very hard to actually to identify it. We've been doing some work with CIPFA recently, working with a number of local authorities to try and get them to start, or working with them to develop a framework to allocate the elements of spend that they are doing, so that you start to get a picture of what preventative spend actually is, because I think it's quite hard to shift into preventative spend if you don't know what you're spending your money on. I think there's also, definitely a consideration of kind of the long-run return, and I suppose this is a more structural thing in that if you think about fiscal events, they tend to have the focuses on a 5-year horizon. Sometimes that 5th year, there's question marks about the kind of plausibility of assumptions made even to the 5th year. But with prevention activity, you know that investments are very likely to have their return over the longer term. Just thinking about something like employment changes, some work that's been done to look at an increase in the health of the population and the impact on employment. Kind of 60% of the economic gains from that are appearing over 5 years after that gain in health. So if you don't have a long enough time period over which you're assessing sort of the benefits, you're not going to prioritise those types of policies. And I suppose, again, more practically, it's cross-government working. And I think the things we're hearing about where people have more experience of actual local interventions and working on the ground, I think some of the ways in which programmes are delivered or budgeted from central government can get in the way of people working together more cohesively on the ground. So I think there's a question about kind of trying to shift and create the conditions for local areas to act better together and be able to work in a more preventative fashion. And I suppose the kind of moves towards greater working between local governments and health boards locally are potentially steps in that direction. I think you asked specifically about investments. I suppose in one way there's one very big policy that has had a lot of backing, which is auto-enrolment, which is I suppose a really, really clear case there, but it's a very, very long-term policy before you'll see the benefits. So there are at least examples of things that have happened and have been very successful. I think one in a shorter term and with a more, I suppose, direct impact is thinking about cold homes again, where analysis there has shown that there's a 900 million a year cost to the NHS from cold homes, and it would cost £6 billion to fix those problems. So within about 7 years, you would get that kind of payback. I mean, obviously, it depends how you structure the improvements. So it's not. So I don't think they're not all very, very long-term benefits that can come back. And I think more anecdotally, we hear, I suppose, where you do hear about people working together more locally, things like being able to move people back into homes instead of in beds in hospitals can be a big cost saving as well. So I think if you can get case studies and examples, there are examples of much more immediate changes that can be made that could help to get a return more quickly.
Thank you, and I absolutely agree with you. The long term, it's a challenge for governments to look more than 5 years ahead at the most across any issue. We heard earlier from Dr. Attwood about fantastic work going on in the southwest. To what extent do you think that how can we scale that up across the country, or is it already happening in places around the country? Anyone want to take that on?
It's talking specifically about proactive identification of
frailty. Sorry, yes,
yeah, absolutely. So it really varies between the integrated care boards across the country. I think there are some areas that have people like David who are real passionate advocates for this and are quite far forward in their frailty journey in terms of identifying their population and introducing sort of system-wide approach. But it is not consistent across the country. I mainly know about England, apologies. But we are working at British Geriatrics Society with the integrated care boards to try and produce some sort of policy documents that can help shape that in a more systematic way. Was there two parts to that question? I've lost my train.
Well, to what extent it is out there, and how could we scale it up?
I think it will be at an ICB level. Mm-hmm. I think also, just once again to mention the voluntary sector. Our most recent publication from the Society again was all based around how important the voluntary sector is at a local level in delivering this sort of wider determinant of health agenda. Certainly Age UK are the charity I'm most familiar with locally. We have a navigator that sits as part of our health multidisciplinary team and is incredible at sort of helping people access the social prescribing side of the things that keep them well. And I know there's big projects going on in Leeds, but it's all kind of pockets around the country of where champions really have managed to gather things together. So I think some more national leadership around that would be really valuable.
Thank you.
I think picking up that theme around national leadership, the big challenge that we have in the context of end-of-life care is that so much of that is being channeled towards hospitals because the community services just aren't there. And we've got a situation where since the Health and Care Act 2022 in England, responsibility for commissioning the palliative end-of-life care that's been a legal duty on ICBs, but we've not seen that prioritised. And where you've got end-of-life care services which are so dependent on charitable fundraising to meet their costs, we're not seeing those services, but there's pockets of really good practice, but we're not seeing that consistency and equity and access to services across the country. So we'd say that we need to see much greater national leadership on end-of-life care. We haven't had a national strategy since 2008. We think it's about time that's addressed, so that we can start thinking about how we address inequalities in access to end-of-life care, but also some of those wider inequalities that impact that.
Thank you. Anything to add on?
Nothing significant. I think the observation about champions is, I think, really important, because you do tend to find that the pockets tends to be related to can often be related to specific people who have been very enthusiastic and driven the change through. So I suppose it's really thinking about how can you create the conditions where that's happening in a more widespread way, which is probably partly about trying to insert those champions in other areas, but also I think to some extent from a national perspective, it's about making it easy for people to start to make those changes so that there aren't kind of significant barriers getting in the way of people improving things.
Thank you.
Thank you. Frank McNally.
Thank you very much, Chair. And I thought Sir Michael was still here. In Sir Michael's evidence earlier on, he spoke about the impact of the change in the state pension age, particularly on those who are living in poverty. And David, I'm conscious that the Health Foundation has cited its concerns about increasing the state pension age, particularly regarding the existing health inequalities and high poverty rates for those who are just under the state pension age. So can I ask you for your assessment of the impact that you foresee the changing of the state pension age will have, particularly on those who are already living in poverty?
Sure, and I think there's probably a slight backdrop thing to this is that the longer term trend where we're seeing life expectancy gains stalling over time, and I think there's often mixed sort of understanding of what life expectancy actually is the measure, and often the main measure reported is about people's current mortality rates now, and the one to think about more for state pension age is your kind of cohort life expectancy. So how long do you think the people reaching state pension age in a given year will live beyond state pension age? And when you look at that measure, what the effect of that slowdown in mortality gains is that actually it's been revised downwards quite significantly since around 2008 and 2010. So we're now expecting, I think, someone aged 65 in 2020, or sorry, the 2020 cohort of men, aged 65, we're expecting them to sort of have 20 years in retirement, but that's 2.7 years less than it was expected for that same cohort about a decade ago. So there's been quite a significant downgrade in longevity. It doesn't quite seem yet to have hit a point where the people reaching state pension age in the next 10 years will have less time in retirement than the people in reaching state pension age now, which I think is the really important thing to be thinking about, is will future generations have as long in retirement? So, but that's been the kind of the trend effectively. So I think if there isn't an improvement or if there is a worsening, that will start to move in the wrong direction. And then there is also, I mean, I've talked about a lack of data before. There's not good data on the sort of future time spent in retirement in good health or not, because it tends to be based on current health patterns effectively. But when we've looked at things like current mortality patterns across regions, what you can see is that in certain regions and in more deprived parts of those regions, life expectancy has actually been reducing. So Scotland, the North East, East Midlands and Yorkshire side and Humber were all falling behind the least deprived areas in the period before the pandemic. Because I think the pandemic has obviously had a big effect on mortality and confuses those trends a little bit. But I think the picture would be that I think from that you could sort of think that if those patterns are continuing, the people retiring under age 67 and possibly beyond, you will start to see the people living in more deprived areas particularly falling behind, and having the increase in state pension age is effectively taking a greater share of their life in retirement away from them, which I think is a really key concern, and particularly because I think it's work the IFS have done in looking at the last state pension age rise from 65 to 66, where one of the really key impacts was that it increased absolute poverty for that pensioner cohort age 65, increased to 24% instead of what they estimate would have been 10% if the state pension age hadn't risen, and a lot of that is concentrated in people unable to continue working. And I suppose that goes back to the point that if you're not in work, and if at age 65, unless you've kind of voluntarily retired and can quite easily go back and find other work, it's potentially reflecting that you're unable to work anymore due to your health, and your chances of going back to work at that point are really slim. So I think if you couple that with trends we've seen around incapacity benefits over the last sort of few years as well, I think there's a real risk that you'll have a bunch of people who are effectively likely to be thrust into poverty by the rise to 67.
Again, and just I suppose to all members of the panel to conclude, we know where we're going in terms of the state pension age for now. Are there any particular steps that you think the government can take to mitigate some of the challenges that you've just outlined there, David?
I mean, I think the two big ones. I mean, there is employment support. So I think it's challenging for a group who've been out of the labour market for a while, but perhaps a focus on preventing people from falling out of work in the first place, particularly, and probably working beyond state pension age to some extent where that's possible. And I think the other option, really, it comes because there's not a lot of other options, is financial mitigation effectively. So something I think along the lines of has been discussed before, of effectively topping up people's their benefit income to reflect more that you would receive at pension age, I think, rather than at working age, because there's such a big gap between the two.
Nothing further to add on that, thanks.
So, refer you back to my earlier comments, really, that because of the change in the state pension age, more people with a terminal illness will die in poverty. We would suggest that in order to mitigate that, people with a terminal illness should be guaranteed a state pension level equivalent if they've got a 12-month diagnosis.
Thank you.
Thanks. Thank you very much. Just a final one, since we're actually ahead of time, which is very unusual. And it's really about what recommendations that you would like to put to the government if you were a member of the committee. Toby, you've been quite forthcoming in terms of making sure, for example, care pathways around non-cancer diagnosis for end-of-life care. I think that's really, and that you had a couple of others as well, which I've made a note of.
I think it's looking at the special rules for the end of life again, and being clear that in other benefits, so for example, one example is around attendance allowance. If you're subject to the special rules and you apply for attendance allowance, the requirement that you have had a condition for 6 months is waived. But if you don't have a prognosis of 12 months or less to live, even if you have a terminal diagnosis with a prognosis of 13 months to live, you do not get access to attendance allowance on that fast-track basis at the highest rate. We think that's something that should be addressed.
Thank you, very helpful. Ruth, what would you like to see?
I think just back to that message of creating health and not just preventing disease, and particularly that healthcare services should be designed to support the most frail, most complex users, rather than blaming them when the challenges that their complexity presents. And it might be a good point to mention as well that we don't have a commissioner for older people in England like they do in Wales.
We were in Greater Manchester, and that was a very strong recommendation that came out there. So,
because so many of these issues are cutting across all the committees, and you know the same messages in each. And I am sort of concerned the 3 pillars of the 10-year plan, whilst we obviously support them, they're not going to hold up without that underpinning of the wider determinants of health.
Can I ask? So I remember working in the NHS at the time. So in terms of the National Service Framework for Older People, and whether it's time, and thinking about the sort of rollout of a sort of a national approach to that doesn't rely on just wonderful people like Dr. Attwood. Is that something that would help, do you think, in terms of focus attention around a national approach to healthy ageing?
Yes. It's a quick answer, but it's been attempted multiple times, and obviously the current restructuring NHS England is going to make the work that has happened more challenging to roll out, I think, but we will keep going.
Thank you. And what about you, David? What would you like to see?
Sure. Well, I think there's a kind of, I suppose there's a bigger picture thing about the shift towards a more preventative approach and actually treating people's health and thinking about poverty through the lifetime so that you don't get the kind of disadvantage that you see. Because I think that is really the only way that you're going to get significant inroads, although it will take time. But really having that, I suppose, ultimately the focus on determinants of health underpinning the 10-year plan and generally the kind of, I suppose, the health missions and government policy in the area. I think probably more specifically, I think there is something about having there being the availability of kind of flexible financial support for people, because I think particularly if you're in a situation where you have limited funds and you can't change that income for whatever reason, and particularly for pensioners, you ultimately will need some financial support to prevent things getting worse in that situation, so maybe at a time of crisis. And then I think and by crisis I mean both a kind of global shock type crisis, but also perhaps someone's washing machine breaking as well and then needing to get it fixed. And then I think the other route really is trying to deal with some of the underlying issues. So some of the things we're talking about are consequences of so things like cold homes. That's really, you don't have to have an income boost for that. You can deal with that by improving the quality of the housing stock and pressures like energy costs as well, which can be, I suppose you can work towards trying to reduce some of those costs. So I think there's probably a kind of 3 broad approaches to sort of try and mitigate issues.
And just a very, very quick one. In terms of social prescribing, that is becoming more and more prevalent, which is fantastic. But again, is that something that could be used more widely across the NHS for older people?
I mean, my experience locally is that it is very well embedded, both in primary care and in the sort of proactive services that are running. But as we've already said, I think it's probably quite patchy depending on which area of the country you live in, and access to healthcare services is more difficult, including access to a GP in a deprived area. So again, it's just that knock-on effect.
Fine. That's so helpful. Thank you so much. It's been a very informative final panel for this evidence session. Thank you.